arguing with a woman only the other day, thinking, why am I having this argument? This is ridiculous. My little Charlie needed antibiotics. And I said, well, there's no evidence at all. You know. But there we are.
Yes, please.
Wong, layperson. Found your presentation very fascinating. 3 points of interest. Firstly, the reference health tourism. Wanted to get some advice. Seemed to be a bit against it. Secondly, the aquaculture. Saw a documentary that was locally shot, and it's quite damning evidence that fish are being infected with sea lice and causing quite a bit of repercussions. CO2 increase in the waters, and basically the downfall of fish stock. And the third point is the 100,000 project. Would you give any advice for a person who wants to get on board there?
Thank you, Mr. Wong. Health tourism. We have quite a number of Brits who go to India for actually cosmetic surgery, or sometimes for transplants and things like that they can get there, that because we have a waiting list they can't get. And I think it's important that they understand they can go and buy services over there that are cheaper, and dentistry, than in the UK, but there are risks involved in that because people come back quite often with bugs that then the NHS has to pick up, but some of them are very nasty. On the fish and the agriculture, one of the things I've learned as a scientist is not to opine on things I don't know, and I confess I'm out of my depth, so you know more than I do. On the 100,000 project, it is only open to patients in the English NHS, because that's where we're sourcing patients from or offering it to them. And indeed, it will be limited hospitals to start with. The NHS England has just run a competition for the centres that want a share of extra money in order to support them doing this properly. So we're going to start with a limited number of centres, and then I hope extend, because I believe that all patients should have that opportunity. And we'll do 100,000, then we'll stop, because that will be the research project, and then see who picks up and goes forward. But thank you for your interest.
I didn't want to give you the impression I was going to move to England, but...
No, I wouldn't. You have very good healthcare here.
Yes. I know of a Londoner, so I thought I'd give her some advice.
Right.
Are you going to max out a certain number? Is it
well, we'll max out at 100,000.
Sure. But in terms of age or other qualifications?
The Science Committee decide that, not me.
Thank you.
Hello, thank you very much for the great presentation. My name is Ilana Gusica. I work at the University of British Columbia Life Sciences Institute. And I also have actually quite a lot of questions about your 100,000 project, but I guess I'll start with one or two. So you mentioned this very interesting structure for the project as a startup company, but government being the only investor. So I would like to ask more about why did you choose that structure? And then there are many other companies, obviously private companies, that are doing similar studies, like Google is doing a similar study, and many other companies in the United States. So is there any particular advantage of a company versus government purely run study? And then in terms of commercialization, who and how is going to benefit from all the data collected, and what is the patient or participant's rights regarding the data? Thank you.
Thank you. So we chose this model because it is government money, so the government must have the final say, which is why we're the shareholder. But, you know, if you want to do something at speed that's really innovative and different, you wouldn't normally choose bureaucrats to run it. You want people who are used to moving at speed and running an entrepreneurial environment and a business environment. And if you want it also to be able to generate income at the end of the day. You need that much more commercial approach from the one that civil servants and government employees normally have, which takes me to your second question. We do hope to generate a profit out of it, but the profit will go back into the system, either more research, which is most likely, or into the NHS, because the money comes from the Department of Health, it stays in that system, and as I say, it's coming out of my research budget, the money to support it, so I expect the money to come back into research. Patients have a right. They consent to join. They don't have to join, and they would be able to withdraw. But as the consent has been very carefully worked out, gone through with ethics committees and everything, we would not expect them to withdraw because they know up front that totally anonymised and within an aggregated database, researchers will be using it. There's no point in giving it if they don't want research on it. Because if they don't want research on it, we won't accept them. So I think it'll be fine. In fact, we've got people, particularly with rare diseases, queuing at the door. I went to visit some patients in the initial pilots on a Saturday morning. One family had stayed in a hotel overnight just so they could come and give their bloods. Another, a child had turned up on a ventilator to give blood. They want the answers. This may give it to them because it's giving them access to whole genome screening. And they want to be altruistic and share their data for the good of others. There is no doubt about that. So I think it'll be fine.
Dame Sally, I'm going to ask you a question from Twitter, and this was a question really, let me try to frame this, is that, so in BC and in Canada we've had significant wins in terms of our intervention with HIV and tuberculosis, looking at it from a public health standpoint. So we've had some early and important wins. And yet this particular person who's tweeting is saying, but yet we don't have government buy-in. So to really expanding this program, what is your advice to us to get more government buy-in?
You need John Bell back. For those of you who don't know John Bell, Sir John Bell, he is a Canadian by birth, and we acquired him when he became a Rhodes Scholar. And he is the life sciences champion of the Prime Minister, so he has direct access. And it is wonderful, the impact that has. So I suppose that might take you through to arguing that your Premier needs a life sciences champion to advise him and to champion the sector. Her.
Thank you. Yes, sir.
My name's Mike Kelly. I'm Medical Director for Life Labs BC. And it's a wonderful talk. I really appreciate you coming and sharing your experience with us. I was just wondering if we could convince you to become a Canadian, because we've been trying for years and years to get governments in North America to do what you've accomplished. And I find that absolutely amazing. If you can get the leaders of your nation to agree that antibiotic resistance is a crisis that needs to be dealt with, that needs to be happening in all the developed world. And if you could come and help us do that here, that would be great. But that's not what I wanted to ask you about. I'm a little concerned about a paradoxical effect of all the things we're saying about antibiotic resistance. I'm also a medical microbiologist. That's my primary practice. And what I've seen over the last few years is that many family physicians have the idea that they are not supposed to use antibiotics, period. And so they've stopped ordering cultures. They're not diagnosing infections as much as they used to be, even in cases where it's clearly indicated that they should be. And even in cases where they do order a culture and we report something back that's significant, and we phone them and say, you know, here's what we think this means, and we suggest maybe it should be treated, we get resistance to that. They don't want to use antibiotics, even for things that are obvious, like typhoid fever or endocarditis. And we have to sometimes argue with doctors to get them to actually treat patients that might die if they're not treated. So what I'm worried about is two things. One is that there's an attitude, well, why do cultures? Why try to diagnose anybody? Because we can't use antibiotics anyway. And then also that when antibiotics are clearly indicated, there's a knee-jerk reaction, I'm not supposed to use an antibiotic, so I'm not going to. And I just wonder if that's a concern at all to you, and if you think there's anything we can do about that.
Well, it is a concern, and that's why I'm very careful never to speak against general practitioners and primary care people, and to explain to the public and the rest of the profession how very difficult it is being in the front line, because they have to make these decisions about what to do in the absence of cultures. I'm horrified if they're stopping doing cultures and swabs, because that is the bedrock of good infection management. And they have to take difficult decisions. The fact that I can show that there is overprescribing, I mean, in Britain and Canada, it isn't as dramatic as in many countries. You should look at the prescription levels of Spain are 4 times ours, I think. I'd have to go and look for the data. And Greece is about 12 times ours. So, you know, we are, all of us, at the good end of what's happening across the world. That doesn't mean we can't improve, but improving should not be at the cost of lives where cultures are not done and action isn't taken. And I think it is a very difficult one. And we get back to education. Education, education, education.
That's the key. The right antibiotic at the right time for the right duration, and not otherwise.
Yeah.
Thank you.
Thank you.
Thank you so much. Marjorie Robbins, BC Centre for Excellence in HIV/AIDS. And I actually spent 5 years developing an Ebola drug and at Tecmara Pharmaceuticals, and we got a $140 million contract for that from the Department of Defense. And at the time when I was doing the work, I kept telling myself, it's such a small problem in Africa, but it could be a big problem. And it seemed like they were funding it out of paranoia. And now I feel like the great irony was that they put so much money into their Ebola drugs and vaccine program, and even early diagnostics for hemorrhagic fever. And ironically, it's coming to do some public good. And it really showed me that we do need the public purse to pay for investigated problems like, you know, the rare hemorrhagic fevers, or, you know, antibiotic resistance isn't rare, and yet it's not profitable. So it seems to me like a no-brainer. We need to fund these things, and yet in Canada, as been said, we're losing research funding. You know, so yeah, it's another case of the obvious, and yet we need a champion, I think, here in Canada. Same thing for HIV. The pipeline is drying up, the AIDS drugs pipeline. And so our team is trying to make sure that we can reduce resistance and keep the pipeline intact for the world and for Africa, right? So we're all interconnected. So thank you so much for driving that home.
Hi, my name is Robert Young from Simon Fraser University. I also used to work in pharmaceutical industry. And I relate very much to your issues with antibiotic resistance and how one can make the research community work towards developing new antibiotics. I know I saw in my company, people work extremely hard to get the perfect drug. And I saw their data. They threw away vast numbers of not quite perfect drugs. So I'm wondering if perhaps the future may be, rather than to get the perfect broad spectrum antibiotic, which no one will use, is to be able to say, let's get a very good narrow spectrum antibiotic where we can give it to the right patients and actually be confident that it will be used, and you can guarantee almost the market, and therefore you will drive a market.
I think that will be one of the approaches. Another will be to fish many antibiotics out of the dustbin and say, so why weren't they, you know, if they worked, what was the side effect? Can we get rid of that, or can we tweak it? I think there's a lot of work to be done like that, and it'll take time to kind of get to that position.
Because of small isolates were not being effectively treated, and they were very small numbers of isolates, so because they wanted to treat them without the diagnostic component.